Andrea is the Chief Medical Officer of MDVIP. She also serves as the Executive and Organizational Leader of MDVIP's Medical Advisory Board and supports quality and innovation in the organization. She oversees MDV's impressive outcomes data, and that's what she's going to talk about, their published studies. She's board certified in internal medicine and endocrinology, fellow of the American College of Endocrinology, received her her DO from New York College of Osteopathic Medicine, completed her internal medicine residency at Cabrina Medical Center in Manhattan, endocrine and metabolism fellowship at Medical College of Georgia in Augusta. So please welcome Andrea.
Thanks, Tom. Is this working? All right, now I hear myself. Morning, everyone. First disclaimer, you notice the title here is not the title in your agenda. The one in your agenda was really long. I didn't think I could fit it on the slide, and I actually went back and forth with Tom and Bill a couple times to make the title what I wanted it to be, but I thought the real down and dirty is really like, what are the real facts and does it work? I know I'm speaking to the choir for a lot of you here, so excuse me as I'm setting up that the healthcare system's broken and all. Maybe there are some facts here that as you guys are out there speaking, you could use also. A little bit, Tom told you a little bit about me. People laugh that I do things in 10-year chunks. I've actually sat in your seat of deciding how can I make my practice better and what can I do. I was in private practice in Tallahassee, Florida for a good number of years. And in the early 90s, in the late 90s, when MDVIP was being founded on the east coast of Florida, I was on the west coast also struggling. We had the highest penetration of managed care in the country back then. Seen the pendulum swing a couple times since then. And I was trying to figure out other things to do. My passion was women's health and osteoporosis, so I started doing a lot of talks on osteoporosis. Ended up going to work in pharmaceuticals. Friends all said to me, oh gosh, how could you go to the dark side? How could you do that? And I felt like I could help more people better that way. Hopefully some of this is ringing true for why you're all doing what you're doing. Went to work for P&G Pharmaceuticals, ended up moving up to Cincinnati with them. And then when P&G bought MDVIP, they sent my old head of pharmaceuticals down as CEO, Dan Hecht, who I think some of you know. Dan was running MDVIP, brought me down, and then when P&G sold MDVIP, I got to stay with the company. I begged everybody, please don't send me back up to Cincinnati. Let me stay working for MDVIP. So I've been there for the last 6 years. I'm very honored to be able to really prove what that network does. And so that's a lot of what I'm going to show today is all of our published studies. And so as I said, I'm going to talk a little bit about what's wrong with healthcare, primary care today, and really how concierge medicine, or really the MDVIP model, works and all of the data behind it. So I think, all of you have a favorite picture of what's wrong with healthcare, what it used to be like. I've used a picture of Marcus Welby, and then you go to the picture from New York Magazine of Dr. Rage. But, as you know, this is what it used to be, and this is kind of, I have a family of Star Wars fans, sorry, kind of where we are now. And then the government, as you look at the spending in healthcare, so what is wrong with healthcare? We know that over time, inflation has stayed sort of the same from when Medicare started. How much we've spent in the gross domestic product goes up a teeny bit. National health expenditures, even more. And then what we've spent in Medicare goes way up. And so you know that this is one of the biggest problems of the healthcare cost is we're spending so much in Medicare, and the money we're spending there is even higher than anything else in spending in the government, except for the interest, I think, is on the national debt. And we thought the ACA would help, right? Wrong. You can see legacy healthcare spending and ACA spending. So we're spending more and more. Now, if we're spending a lot of money, wouldn't it be great if we're getting better care? And everybody practicing medicine was happy, and patients were happy. Well, it doesn't equate to life expectancy, because we have one of the lower life expectancies. In fact, our health outcomes are on par with Cuba and Slovenia. So we're not getting longer life expectancy, we're not getting better health outcomes. I mean, when you think about what should we be doing to change things, imagine if 4 jumbo jets went down every day and everybody died on board, right? For a year. Do you think anybody would do something about that? I mean, the government, the FAA, somebody would be yelling and screaming. That's how many people die of heart disease every year. Yet, the average traditional practice physician can't work on preventing that disease because they don't have the time, because they're just trying to keep their doors open and seeing a lot of patients. We thought the Affordable Health Care, the ACA, the Affordable Care Act would help that. And this is what they wanted to do. Do we know that it expanded access? Well, there are more people in the system, which means longer waits for many people. We saw the cost piece. And I don't really even want to go with the quality piece. I mean, people talk about what is the definition of quality. You know, I mean, that's the big thing. The government's definition is, did you check the box for PQRS and did you give somebody smoking cessation counseling? I don't know. I think maybe preventing disease is probably the best indicator of quality. And so I stole this chart from Dr. Ovik Roy, who speaks for us at times. And Ovik paints this miserable picture of where the government's going and what has happened to healthcare. But I always like this chart. He lets me steal it. And it starts with, it's really healthcare in one slide. Government subsidizes health insurance, back with Medicare. Consumers become insensitive to healthcare costs, and especially when I talk to, you know, my mom, my mother-in-law, they have no idea what anything costs because they've been on Medicare their whole lives, and they don't really think about, well, not their whole lives, since they've been 65. And, you know, they say they need this test, and they have Medicare, and they have a supplement, and so they're going to get it. And so what happens? More tests, more revenue for hospitals. Hospitals expand to reflect this increased demand, and they keep making more money, as we all know. Government spends more. Government has to cut payments somewhere because they can't keep spending, so who do they cut? Who gets cut? Of course, all of you in the room, as you know. Hospitals are merging, gain more power. Private insurers increase their premiums. They're unaffordable for consumers, and we get into that vicious cycle. This slide he put together a few years ago, and as and it's still true today, but, and I think it was last night at dinner, it was Marcy, I think, made the comment about how complicated the government and healthcare is, and I think this is the slide that they use to how they describe the healthcare system today. So things are very complicated and spending more and more money, and we know it's really not helping anybody out. And primary care has taken the brunt of a lot of it. I think all of you know this, but there are more patients. We in MDVIP, so we have 260,000 patients across the country. We have 260 people over the age of 100 in MDVIP. People are living longer, and as they live longer, they have more and more issues, more complex, more changes in healthcare. You know all of these things, and for many of you at least, you're not sitting in the less reimbursement, less time place, but most traditional docs are. And even as concierge docs, I think a lot of you feel this. I saw this from Medscape recently, well, it was probably a year ago. You know, just how physicians get squeezed. How can you see 30, 40, 50 patients a day and keep up on genomics? I guess we have a vendor here who can teach everybody about that. Keep up on everything that's happening, EHR, MU, PQRS. And I know we'll hear a little bit more about macro, but now there's macro and MIPS all talking about how they're squeezing physicians. And patients don't have a good time either. When I do interviews, a lot of times I'll talk about the rule of threes. It takes 3 weeks to get an appointment, 3 hours in the waiting room, and you get 3 minutes with the doctor. A little bit of an exaggeration, but it's really true when you look at all the data out there about, you know, even when Massachusetts was sort of ahead of the curve for the Affordable Care Act, and they started having 4 to 6 weeks for appointments. You know, you're sitting and waiting in waiting rooms. Of course, you all have no wait waiting rooms, so nobody's waiting for you. But the interesting piece, we did some consumer research, and in traditional practice, you know, many patients say their doc really doesn't seem to listen to them. Because of course, there's somebody knocking on the door, they're going out the door, their beeper's going off, and there's always that hand on the door thing of, you know, well, anything left? And you know, how many times had you back in your old practice, and I can even remember from my days, you know, somebody's sitting there and you know there's something you got to get to, and you just didn't have the time to probe and ask them. And as, I mean, all of you know, patients are dissatisfied, and this is really the driving force for where we are now. And physicians aren't immune to the dissatisfaction and unhappiness. There was a study in Mayo Clinic in 2012. They updated it in 2015. Burnout, about 50% in traditional practice. You know, the one thing I found a stat, I think it was in Medscape actually. We lose 1 medical school class a year, that number of physicians, due to suicide. Physicians commit suicide at twice the rate of their patients. So we're not immune to all of the pressures and the burnout. And there are many physicians out there who just really don't have, the only word I can think of is chutzpah, to do what a lot of you are doing. I mean, they really don't want to take that risk and aren't comfortable making a change in their career. And of course, this has negative consequences, and primary care is worse. I actually just sent this slide. I changed my slides on the plane yesterday because this just came out this week. Physicians Foundation does that study every year. And this year's, again, 50% of docs say they're going to do something different. 50% say they're burnt out. And actually in 2014, 6% said they would go switch to concierge medicine, and now it's up to 8.8%. So more physicians are looking at what can they do, what are their options. Nobody's happy, and then the medical outcomes aren't there. We talk about finding the risk of heart disease. Not only are patients not getting the preventive services they should be, they're not getting the time that they should from their physicians. Outcomes are not going the way they are, and this impacts costs tremendously. 85% of the healthcare costs are on treatment of chronic conditions, and we could prevent 50% of these. So you could really impact all of that spending, and that's what some of the data I'm going to show you today that we've published from MDVIP showing that, you decrease hospitalizations, you save money. You give better care, you keep them out of the hospital and the ER, you save money. So this model of care really does work. People will always ask me, why does MDVIP have a 600 patient cap? How did you get there? And it was funny, back when the company was founded, and I know many of you in the room know the original docs of Bernie Kamenetsky and Ed Goldman, and when they were trying to figure out, how the model would work, there was an article in New England Journal just before that, sometime in the late 90s. There have been since articles in the annals, archives, everything has had an article about how much time you really need to focus on prevention and wellness in a practice, on top of putting the Band-Aids on all the chronic care issues. And so when you look at, well, you really need about an hour and a half a year for an extended physical annual visit. You really need to spend time, probably a couple of visits a year for half an hour to make sure that you can, keep going with the prevention and wellness focus, and give yourself a couple of weeks of vacation. It really ends up to a max of about 600 patients a year. So that's how we came up with that cap. But as you know, the numbers across the country, and I'm hoping Michael's going to give his little spiel he gave me last night about, there is probably how many we know and how many we don't know and where we're thinking with the numbers. But practices are very different across the US. There are some that have smaller panels, some that have larger panels. And fees definitely vary also. But the core concepts that I think from all of you and that MDVIP have stood on is really by doctors, for doctors, and really being able to focus on the prevention and wellness. The only way to do that is have the time. I mean, I know too many docs that I've talked to that say, I got home at night and I realized I didn't check that CBC or I didn't check that mammogram. And the way most of you are practicing, you do those things during the day and you're done when you get home because you have the time to actually go through the charts and walk through your day and not run through your day. There's a story from Doctor Number One, Rob Colton, who had said for our 10-year anniversary, we did this video and talked to all the founders and some of the original doctors. And he said, you don't remember this, but my first week in practice, in the new model, I called you and said, you won't believe what I'm doing. It's 2 o'clock in the afternoon and I'm researching a patient's disease. And I actually had time to sit down. Of course, this was a lot of years ago and he's a little older, so he pulled out a textbook, didn't Google it. But he said, I'm actually looking at what does this patient have. And that was it was so exciting to him to be able to have the time to do that. And of course, I think all of you, this is why you're here, right? You go into this and you have organizations that actually help you support this to have more freedom personally, professionally, financially. And really, we had our national meeting a few months ago. We invited all of our physicians and their spouses to Nashville. And so we had a room full of over 1,000 people. And I've never been to a meeting where you can have 500-600 doctors in a room and everybody's happy. And everybody's excited and everybody's talking about what I'm doing in my practice, like you all are doing here today. and hopefully at the brakes. But it is just nice when you're not on that treadmill and you're not really dealing with all of the issues that everybody else is. So, and I'll always say at our weekend events, so if, you're happy with the way everything is today, then keep going, enjoy this beautiful resort, and go home and do what you're doing, on Monday morning. But if you're not happy with the status quo, there are things that you can do. And as you know, many physicians have moved to the employed. I think that from what I'm hearing, the pendulum is starting to swing back a little bit. And a lot of those physicians, their 2- and 3-year contracts are coming up, and they're saying, I really don't like increasing my mean throughput every quarter to be able to make the money that the hospital's paying me, and so I want out. But there's still, traditional conveyor belt, ACOs, everything that's out there, employment, and then, there are, I know in our network, there are physicians who are employed by hospitals or by systems and can still do this also. So I'm sure there are other places also, like Mass General is now doing a concierge, having a concierge department. So there are places that you can still do this and be employed. But I think most of you are the type who want to be the independent physicians. It's funny that my title, I actually put concierge medicine on the first slide because we really don't usually use that word at MDVIP at least. Usually use personalized preventive care because we feel like that describes it more. The problem is people don't really understand what that is, and you have to take 10 minutes to explain what personalized preventive care is, so it's easier to just say, oh, concierge medicine network. I'm going to just hit my builds here. So all of you know this. Paying an annual membership fee anywhere. I did meet a physician who is out in a different city than you are, Tom, in California. Charges about $30,000 or $40,000 per patient, but he's the type who goes on your airplane with you, travels with you, so I know that there's the gamut. That's not what most of you in this room are. You're all more of the take care of my patients, not charge that much money for things that just really aren't, I don't want to say relevant because they're relevant. If you want your doctor to travel on vacation with you like the president has, then that's nice, if you can afford that. And all of you know, really traditional treating sickness versus preventing disease and having a little bit more of a holistic approach to be able to take care of the whole patient. So we put this together probably a couple years ago now, looking at kind of the landscape. I'll find my pointer, there you go. Mixed models or hybrid if you're doing some concierge and some traditional practice. Something more where you say, you're opting out of everything. And I think the big difference between these types of models are you continuing to take insurance, commercial? Are you continuing to take Medicare? And you need to worry about federal law and commercial law? Are you opting out of all of it? And, and what are you for? I know there's everything from newer models out there that are like $150 a year. And you just sort of get a technology platform and appointment scheduling. And so there's a gamut of types of models really coming out, which is likely why the numbers keep going up, because there's a lot of people doing a lot of various things that could be in the concierge medicine bucket. So teeny bit before I do my data on what really MDVIP is, in case any of you don't know, national network. The 750 numbers there. So we talk about signed physicians in MDVIP and open physicians. So we have signed, it's about 890, I think, now across the country, who have signed up with MDVIP and either are already practicing or in the queue to practice. We have about 760 or 70 who are already open. So that those 100 are in the queue or are in the middle of a transition. As I think most of you know, MDVIP gives you a 4-month transition, puts somebody in your office, and helps you transition to this model. So that's the difference in those numbers. We are everywhere now, from Florida to Maine to Alaska to Hawaii. We have our first doctor in Alaska over the last few months. And a lot in Hawaii, so to your point of having doctors to call when people are on vacation, Tom, there are physicians there. And have over 260,000 members. And so the way our model works is the patient is paying for a host of non-covered services. One of the things that, since the beginning, when Ed Goldman, who is a physician who's one of our founders, was really looking at how do you support something where if you really want to take care of your patients, you need to have less patients. And you can't keep your door open if you only have 400 or 500 patients and are doing just insurance. And Ed went everywhere, to commercial insurers, to patients, to physicians, and to CMS and everybody, to say, you know, who can pay for this so the doc can practice this way. And it came down to the patients need to pay for it. And when he was in with CMS and ARC and Carolyn Clancy, and they all said, well, if they pay for non-covered services, you won't run afoul of Medicare law. So that is where we sort of started everything, to say patients are paying for these non-covered services. These non-covered services wrap around what's covered so that you get an executive style physical. Worth Magazine actually last year named us one of the top 10 executive health companies in the country, up there with Cleveland Clinic, Mayo Clinic, all those places. And the funniest part is, we're not an executive health company. We're a network of primary care physicians taking care of their patients across the country. But because of the way the services are, it was nice to have that recognition. And this is sort of an eyesore of services. And you're not supposed to be able to read them. But just to the point of, this is how we talk about things that, you know, we wrap around what's covered by Medicare. And so all of our other services are the non-covered things that Medicare does not pay for prevention and wellness screening. Patients, just like in your offices, same or next day appointments, unhurried visits, you know, your cell phone number, chronic disease management. We have a reciprocity program, so to Tom's point before, all of our doctors will see other MDVIP patients across the country. Yes, I mean, I love for y'all to take advantage of that too, you know, call other MDVIP docs, because at least, you know, it's not like it really is any skin off anybody's back. They still bill insurance. So if the patient has insurance, they're still getting paid for that visit, but at least they can help everybody out. We have relationships with places like Mayo Clinic, and also we help facilitate those referrals. But I think the most important thing about having a network of this size is actually to be able to collect data. And so that's the difference between having some independent physicians across the country, but having, you know, 750 across the country. And to Tom's point about the EMR, we were actually just switching EMRs in MDVIP. We were on EMDs, we're moving to Athena now. And so as of today, we have about 300 on Athena, and we're moving towards getting the rest of the docs on. There will be those few who are employed and can't leave Epic. But my hope is to get most people on there, because then I have data that I have aggregated data that I can just look at and publish to say, you know, this model works, this type of care works, and have more data to support it. But so we have 8 published studies so far. I'm not going to show you data from all 8, but I'll show you quite a bit of it. And I kind of put it in different buckets. One is really that care. Are you decreasing risk? Are those non-covered services really worth it? We have patient forums as somebody's transitioning, so the doc stands up in front of all their patients and tells them why they're doing this. And one of the questions always comes up is, well, why should I do this? You told me I was healthy last year. Why should I pay for you this year if I'm really healthy enough and I don't need these services? And so if these services are truly identifying more risk than you would get with covered services, that's a good answer to that question. I'll show you that data. Then there's the buckets of looking at decreased, you know, costs. So the better care of keeping patients out of the hospital, keeping patients out of an ER and an ambulatory care center, decreasing readmissions, and then, you know, better outcomes and patient satisfaction. So my first study, the slide looks a little bare, sorry. In 2011, when the Affordable Care Act came out, we revamped our services. So in January of 2011, we have a really good point to say, okay, what have we been doing over time? And after about 10 months, and many of you may know, we have a relationship with Cleveland Heart Lab that came out of the Cleveland Clinic, and the labs in the MDVIP program go to Cleveland Heart Lab. And we have advanced lipid testing, cardiac inflammatory markers in there, and A1C, a host of other things for screening. And we put a stake in the ground one day. It was about 10, 11 months out, and at that time we had 95,144 people who had had our lab panel that included a myeloperoxidase, the cardiac inflammatory marker, VAP, A1C, CBC, CMP, UA, TSH, and a vitamin D. And so 95,000 people, as all of you know, in any study is a huge cohort. And so what you find, you're pretty sure is really what's happening. And so of those 95,000, we found 30% had absolutely nothing abnormal, even all those little pieces of the VAP. But that means that 70% had something abnormal. Did I say normal? 30% were normal, so 70% had something abnormal. But if you only have one biomarker, for example, identifying cardiac risk, you're going to miss people. 30% had only one marker abnormal, meaning we missed 40%. I know, it gets confusing, it's easier this way. If you look at an LDL, a covered service, something that Medicare will pay for once every 5 years, commercial insurances pay for a basic lipid panel, usually every year. Whether you used an LDL of 100 or 130, the numbers were like very close in percentage points. One was 29%, one was 30%. But let's say 30% are known to be at risk because they have an abnormal LDL. We identified 11%, or over 10,000 more people who had a myeloperoxidase abnormal. Myeloperoxidase is the cardiac inflammatory marker specific for a vulnerable plaque. So, do you have that plaque in the blood vessel that's ready to burst open and cause the clot and close the event? Predicts having an event in the next 6 months to 2 years. As I'm hoping most of you know, half the heart attacks happen with the normal cholesterol. You need to look for inflammation. And so identifying these people at risk is very important. An example, when this paper came out, I talked to a lot of reporters. And, do they get cardiac inflammation? Do they understand the difference between lipids and all? And of course, now it really makes you laugh with all that came out recently, that the Sugar Association paid off all the Harvard scientists to say it's fat, not sugar. And so we know inflammation, a lot is from glucose intolerance and, the root of the sugar problem. I brought up as an example Tim Russert. Everybody remembers Tim Russert, the journalist, died 3 months after a stress test with the normal lipids. Well, nobody ever checked his advanced lipid profile. Nobody ever checked his myeloperoxidase or an inflammatory marker or even a CRP. If they had, maybe they would have known he still has risk, he still has inflammation, and he could have been treated. The other thing that having multiple biomarkers does is sort of stratify your risk. So if I'm a new patient and come in your office and my LDL is 160 and say, please send me home and diet and exercise, I'm betting most of you would say, all right, it's not going to work, but go home for 3 months and try it, and we'll see what your LDL is when you come back. But if your LDL is 160 and your myeloperoxidase, your inflammatory marker is abnormal, you don't go home on diet and exercise, you're at risk for an event in the next 6 months to 2 years. I'd probably go home on a statin and aspirin or whatever else you were going to put me on. So it really can help re-stratify the risk. So having this data set has helped us identify that we're identifying more people at risk. Now the next step, we have 5-year data now. We know that this myeloperoxidase has come down over 5 years. We know that the lipids in the A1C have actually been pretty steady. What I need to do is get the clinical data to show that the events have come down. My doctors tell me that. They'll say, we don't have people having heart attacks or strokes anymore. And so we've just started that study with Cleveland Heart Lab to be able to show if I can say, decrease your risk of heart attack by 50%, 40%, whatever. At least we're showing that this care is really doing it from the clinical perspective. Now my next study, looking at better outcomes, this was actually a down and dirty study done because about 12 years ago, 13 years ago, Blue Cross Blue Shield kicked all the docs in Arizona out of network. I can tell you that MDVIP docs are 94% in network across the country, and some of the percent who aren't are the ones who don't take any insurance. But there are some areas where they don't want concierge physicians, whether it's because they say these are covered services and they don't believe in the legal and regulatory framework of the model, or more importantly, they say, well, our patients can't see you without paying a fee, and we don't like that. So when Blue Cross did that, I was here 2 weeks in the company, and they took me out to Arizona to meet with the medical director, who of course was a pediatrician. And he said, well, I believe your network probably does a better job. Show me some data, which kind of makes you laugh because we all know that the insurance company has all the data anyway. So why they're asking me to put it together, I don't know, but I did. And ended up publishing it because it was nice to get it out there. We looked at the charts of all the docs in Arizona, 2-year study, and looked at, to randomize, did it like you do for patient-centered medical home. You pick a day, you go back a month and a day, and then you identify all the patients that come in with some pre-specified ICD codes. So back then it was ICD-9s. the patients either had an ICD-9 of AFib, hypertension, hyperlipidemia, or diabetes. So everybody was at risk of heart disease, and about half were diabetic. Had a total of 360 patients, so not a very large study, not like my 95,000 of the one before, but just looking at control, blood pressure, cholesterol. You all have these kind of outcomes also. You have the time to make sure that the 50-year-olds are going for their colonoscopies, so you have 85% of your patients end up with them. This was a few years ago before the PSA hoopla. And then our diabetic patients all had good control, just like you guys do, and we beat the top 10% of HMO PPO benchmarks. So it's nice to be able to say that, yes, there are better outcomes because of the time. It's not just, a convenience type of model. So then we wanted to look at hospitalization rates. And actually, MDVIP had been collecting this data for years. There's an IntelliMed database, which is a national database, that there are 5 states that have to report hospital utilization. And these 5 states represent about 1/3 of our network. And so you can see we were following from 2006 to 2010 and looked at MDVIP patients versus non-MDVIP in this database. And this is the Medicare analysis. We divided them, Medicare and commercial. Mainly because most people think that most MDVIP patients are young, healthy, and wealthy, when I think you all probably know they're all the older, complex Medicare patients who don't want to leave their physicians. The average age of our network is 66 for patients. It's not that high for physicians. And so when you look at it, you can see that for Medicare it was 79% in 2010. The commercial number in 2010 was 72%. And you say, well, do you have any more recent data? Not exactly like this, only because in 2011, I pulled, you get the 2011 data like in 2012. So by 2011, 2012, I pulled my docs in these 5 states and said, are y'all still admitting to the hospital? Because this database, I can only pull out, I can't pull out patient names, I can pull out doctor names. And by then, about half of the network who had come in by that time were using hospitalists. So I couldn't really use this database anymore to look at that data. So that's why we stop at 2010. I get pushed on a lot for bias from this study. They say your doctors are different and your patients are different. So we did do a study with Optum Healthcare. That's the side of United Health Group is United Healthcare and Optum. Optum has a whole analytics section. It's the old Ingenix database for anybody who's worked with them. And we went in and looked at our Medicare Advantage patients in the United data and said, well, maybe as a way to take out the physician bias, let's take our MDVIP docs and follow the patients in the year post-transition. And the ones who transitioned with the doctor were the active group, and the ones that did not use as a control group, figuring in a year how much of a muck could these patients run. And what we found is in a year, we still had a 20% decrease in ER visits, 20% decrease in hospitalizations, and saved $87 per member per month. So it's not just the physicians who are great. It's the model on top of the physicians. The holy grail will be, as I aggregate my data now when we're all on one EMR, is to follow the patients. So follow them pre-transition to this model and then follow them post and be able to compare upon themselves. So that way it's same doctor, same patient, and it's just the model to say, yes, this model with these services and this model of care really does work. So I'm working on all that. The cost savings due to this decrease in hospitalizations, and you can see that this was just in these 5 states, we saved $2,551 per patient, more than paying for the membership fee anywhere in the US. If you figure out how much we saved for Medicare and multiply it by the amount of Medicare patients we had in MDVIP at that time, we saved the government $300 million in that year. So you can imagine as the years go on, you save more and more. I actually presented this data to the deputy director of CMS and went in and said, and I finished and I said, so I saved you $300 million last year. And he looked at me and he goes, first of all, and all I could think of is he was going to pimp me. Did you control for this? Did you do this? And he said, first of all, thank you. And then he said, and this was a few years ago, the Comprehensive Primary Care Initiative, where they're paying a little bit more per member per month for chronic care management sort of thing. If I don't decrease the panel size, if I just increase reimbursement by a little bit, it's not going to move the needle, is it? I'm like, nope, it's not. You have to decrease your panel size and have more money to run the practice to be able to take care of patients like this. And I know this is definitely preaching to the choir for that. We looked at readmission rates in this study also, and you can see for the big ones that hospitals care about, acute MI, CHF, and pneumonia, our readmission rates were all the less than 2%, because if you go in, you don't go back in. And part of this is because of the access piece for all of you, right? You get in within a week after being in the hospital. But I think a lot of it is also that you're preventing people from going in the first place. And I can tell you in the study, when we look at the reasons for hospitalization back in 2009 and 10, it was cardiac, it was pulmonary, it was GI. Now when I look at our hospitalizations, what are the diagnoses? Hip replacement, knee replacement, all those things that y'all can't prevent them going in the hospital with. This is another study I did with Optum. So we did the Medicare Advantage. I also looked with Optum at looking at our commercial patients. And interestingly or not, if you look at a commercial patients out that first year like we did with the Medicare Advantage patients, we actually increase cost. Now, does that make sense to you, 40, 50-year-old in a commercial? We increase cost because it's all pharmaceutical costs, because they're more compliant, because you're working with them and they're really sitting there and making them take their medicine and do what they need, and identifying disease early enough that all those pre-diabetics may be on glucophage, or you may be doing something else that you wouldn't have if they were in primary care, a regular primary care practice. So we went out 3 years. And when you go out 3 years, and one of the things I've gotten pushed on from a lot of the journals, first it was hard enough getting some of these articles to be published in journals, because even though there's the call to action and like the annals in all places and saying there's no data out there, there was a point counterpoint in the annals, gosh, it probably was back in 2011 on concierge medicine, and they said there's no data. I quickly, within a week, sent our first paper, the hospital utilization paper, into the annals to say, here's your data. Large network and telemed database, third party did it for us, everything annals should like. Week later got my rejection. I've never gotten such a quick rejection. But so trying to get the data out there and look at things, they always push on me and say, well, if you're talking about costs, you have to talk about return on investment. That's what the healthcare system looks at. The problem here is the patients pay, the healthcare system saves. So you can't really do, like, what's the healthcare system's return on investment, because it's all upside for them, and is there any upside from the patient perspective? So what we did as a poor man's ROI is looked at how many people save more than $150 a month, average membership fee in MDVIP. And you can see that by year 3, 63% of patients had saved $150 or more. And if you want to look at any savings, that's about here. Over 70% of patients saved money, if you look at it, or had a positive ROI by 3 years. And this study actually got picked up by Health IT Analytics, but showed that concierge medicine can save money in 3 years or have a positive ROI just like other population health management strategies. So at least getting a little bit of recognition that we are saving money as time goes on, and that's really what employers are looking for, and others to say, how can we save money? This next one's probably my favorite because it's a little bit of the mushy study. Every year, we send out patient satisfaction surveys to all our patients, and then our field people will sit with the physician and review that survey with them. And it has everything in there from, MDVIP to the physician to the office staff, and really how the patient's satisfied. There are things in there like, did your doctor visit you in the hospital, and other things like that. And not surprisingly, in all the statistics I'm going to show you were stat sig. Not surprisingly, physician relationships were better than conventional, 97% versus 58%. But when you think about it, the bar isn't here, right? For traditional versus concierge, the bar's here. They're paying for you. So if you're paying $1,650, $1,500, $2,000, even if it's $20,000, not in MDVIP and probably in this room, but someplace, if they're that satisfied, they really are getting the value for their money. And all these things are consistent with everything in all of your practice, but I think I like this one the best. They perceive they're in better health. That relationship they have with you, that time they have with you, that they can sit and really have, work through everything, that's what makes them feel better. I'm sure you all have your anecdotal stories. I know we have stories in our network of everything from, one of our physicians always tells a story when he's in front of people that he had an older woman, in his practice, and he couldn't get her chronic conditions under control, her diabetes, her hypertension, and she was really doing everything, and she kept telling him she was doing everything. And he sat there one day and probing, and after like 5 years, she finally said, I'm going to tell you something I've never told anyone, not even my husband. I was abused in the concentration camps. And that opening up, because she finally felt comfortable, was what really was the door that unlocked her getting control of her chronic conditions. I know you all have those stories. But that's the patient-physician relationship that really is getting lost today. In fact, I know my PR director just pinged me. Somebody's doing an article on it of like, what can you do to improve the patient-physician relationship? Just not have 4,000 patients in your practice, right? So I think I am actually on my last slide. So, if any of you are just at the beginning and thinking about this, if any of you are getting near the end of your career and you're thinking about, what am I going to do when I retire? You need to think about everything, research your options, make sure that if there is somebody you're working with that you feel comfortable that they're doing everything, regulatorily. I never know if that's a word, but I use it all the time. Regulatorily and legally right. And, I think just getting everybody together, like in an organization like this, making it a bigger movement, having these numbers that, having voices like Michael's out there to really, I don't want to say legitimize, but I always say to everybody, I don't want people to say MDVIP, oh yes, that concierge medicine network. I want people to say MDVIP, yes, that network with the great outcomes. And I'm sure that's how all of you feel. So I'm out there fighting your fight and trying to publish data to help all of you with that. It's funny, I've been on, and we were talking about this a little bit last night, I've been up on Capitol Hill, I've gone into congressmen and senators' offices, I've been at CMS and ARC, and we tell them this data and they love it. And there's been, 1 or 2 states who actually talked about, could we do a demonstration project with maybe dual eligibles and see if they pay for it? And then it goes nowhere. I don't really know how to answer it except that we just have to keep pushing and keep prodding and keep having people go up there to show them that this is the way that we can help fix the healthcare system. And I know everybody pushes on us about, the point of we're taking away all the primary care physicians. We're not. I said to somebody this morning, it's more the residency slots that are taking away the primary care physicians, and that nobody wants to go into primary care. It doesn't look attractive. But if you can have career paths like this, if you have, I feel like this field is a little bit like osteoporosis. I started in it, and the guys who started as the speakers back in the day are still on the road. They're all pushing 80 right now, or maybe 75. And you need young people to come in and take over these things. You're all going to need people to take over your practices as you're retiring. We need to keep this sort of going so that there is this continuity and people can see there is a career path for primary care in it. I don't know how, I personally don't know how to keep getting it going except that we keep pushing on the hill. You guys keep pushing on the hill, and we all need to keep telling people that we can save a lot of money this way. Hospitals don't want to see it. I've been in front of employed physician groups at University of Cincinnati and multiple places where big groups and with hospitals. And they all say this sounds great, this could be a great career path for our docs, and they don't end up doing anything. And I don't know if it's because the bottom line is the hospital makes their money by the patient revenue, and so they don't want to decrease hospitalizations and ER visits and readmissions or not. I mean, I just don't know what that bottom line is. Or, there is patient demand. I mean, that's, patient dissatisfaction is driving it.
Along those lines, I gave a talk a couple of nights ago to a medical staff in the LA area, 400 doctor medical staff on concierge medicine. And the room was full of doctors, and I talked for 45 minutes, and they asked me questions for an hour. And the only person who had a frown on her face the entire evening was the CEO of the hospital. Mm-hmm. They make their money on admissions and ER visits. And I presented data showing that ER visits and hospital admissions disappeared. And I tried to say nice things about hospital administrators, and I showed that slide that shows that we've had triple the number of doctors since 1970, and 35 times as many hospital administrators. That's the data right now. Somebody else is going to show that slide later. I saw it in their PowerPoint. But we've got 3 times as many doctors, went from 300,000 in 1970 to 900,000 now. And the hospital administrators have gone up by a factor of 35. 35 times as many administrators in the system and 3 times as many doctors. And that exactly follows the cost curve. The cost curve of medicine has gone up almost exactly with the number of administrators. And what we can do is save so much money by getting rid of that middleman. The cost, one of the points I made was, to process a hospital claim is $50 to $100, process an insurance claim. That's what it costs. And if you're doing one $10,000 bill, it's 1%. But if you're doing $1,100 bills, it's prohibitive, It'd be like if you insured haircuts. They'd cost $200 and the barber would get $20. And the administrators of all the insurance system would absorb the rest. So that's true. Next question over here, Jeff. You got a mic? You have a mic now, so I don't have to repeat your question.
I still want to think, I'd still like you to summarize if you don't mind, Tom.
He does a good job.
Anyway, Andrea, I think that the fact that you're here and that MDVIP is here, I think begins the movement further than it ever has been in the future. So I really want to applaud you and your entire team for being here, because part of the thought that I had about this college was basically, one day it's all of the key individuals, but more importantly, all the key players in the concierge movement are sitting at the table determining how we can move the brand forward. Not individual brands, not individual practices or doctors, because I've been to a lot of conferences, Michael and I have talked a lot about this. Many physicians out there are not filled. They have half the number of the patients that they want in their practice, and they're trying to figure out how can I market better to get new patients. The way you market better to get more patients in the door is to make this more accessible nationwide, where employers are picking up some of the costs, Medicare, Medicaid, et cetera, et cetera. How do you see MDVIP in the future perhaps partnering here long-term to perhaps make this the vehicle where we all get that movement going rather than each individual MDVIP, special docs, practice does it individually? Thanks.
That doesn't need a summary.
No. And I have no authority to answer that question. I love being the only medical person on the executive team, and the only female, actually. So I can play the girl card, or I can play the medical card and say, I can't speak for the whole executive team, we'll have to bring things back. But I think that conversations from today, I will bring back to the executive team. We have talked over years about, and I can be honest, we've talked over years about, do we get involved? And then there was the split. Now you have 2 organizations, or maybe 3, right? There's AID also. So there's multiple organizations. I come from multiple organizations as an endocrinologist because I was involved in, and as a DO. So as a DO is involved in the Florida Medical Association, not the Florida Osteopathic Medical Association. I was a delegate to the AMA. And then in endocrine, we had the Endocrine Society, which were the bench researchers. And then ACE, the American Association of Clinical Endocrinologists, broke out since I've been practicing because we were more clinical. So, you have like 5 different people. And then if you want to think osteoporosis, we have the National Osteoporosis Foundation, the American Society of Bone and Mineral Research, the International Society of Clinical Densitometry. So there is a lot out there. And the one thing I can see is they don't all survive, all of them. So have to figure out, can you work together? I know like the American College of Lifestyle Medicine is working with the American College of Preventive Medicine because they can't do things on their own, but when you work together, things do happen. So I'm definitely going to bring back, I know I had some discussion, we had some discussions at dinner last night, and also what can we all do together? I know one pushback we get is, well, we know exactly what our docs are doing. Well, we know mostly what our docs are doing. As you know, we don't know to manage the practices, so I can't force them to do anything, although I'm pretty good at herding cats. And so we can, show our data for what we do, but to the point of, is there more ways to aggregate data, or even put together the other data, or just even say, well, you can say you do something very similar, so is the data close to the same, and coordinating efforts more would likely be there. I can't promise anything as only the chief medical officer, but I can promise as somebody in the C-suite that I can bring it back, and I know we actually have some other people farther west this weekend, so we can really have a talk, going forward of how does everybody partner, and they're not speaking there. They were just, there to get information. But we can see how we can all work together to really further things and make sure that, there's not, I know somebody mentioned, going to see Tom Price, and how Tom Price is saying, we want to make sure they don't put things in legislation that could ever keep concierge medicine out of things. He said the same thing to us. So, how can we all work together? So I promise to take it back, and that's what I can do today.
About that, it doesn't seem to make any sense for the government to limit what we do in any way, since we do so well and save them so much money.
As long as it's not illegal.
As long as it's not illegal.
Because we don't want anybody coming in and arresting you.
No. But do you think there's any serious risk of that? I've been in Washington, D.C. 3 times a year for the last 5 years or so, working with Price and all these people too, lobbying organizations. Pete Sessions is a good friend, and Cassidy and all these people are really good friends. And Marcy has been running an organization that helps us go to Washington, D.C. and do that. Thank you, Marcy, welcome you got here. Our other board
She's been
member.
here for a while.
I know, but she's got a little while. But do you really think you have your finger on what's going on in Washington? Do you think there's any chance that the government will in any way restrict us?
And I'll say the government and then states and other things. So if we start with the government, and as long as you're not running afoul of Medicare. So I think with the gamut of physicians that are out there doing this, we don't know what everybody's doing. If you are taking Medicare, and if you are not billing for access and you're providing services for the money that you're charging, medically relevant services or services that a patient will pay for if it's a technology platform or something else, as long as there are services there, we have an analysis of our services that shows that the fair market value of those services equals the membership fee anywhere. So we feel pretty good that those services equal the membership fee, and so we're not running afoul of Medicare. If you're doing it the right way, I don't think Medicare or the government's coming after us. I mean, Tommy Thompson wrote us that letter how many years ago? Tommy's still around and alive to fight for us. And so Medicare, I don't think so. Now, we still constantly will get letters from state attorney generals and others saying that, you're not legal in the state. We went through it with New Jersey, we went through it with Maryland or something. And so then our lawyers, all get together and go fight it, and we win. So you need somebody behind you fighting for those things because it does come up. So, one of the things we always talk about, even at our national meeting, is, I don't know if any of you met our general counsel, Roy Harris, but he's like this big and this big. He's like our bouncer. And Roy will go to fight for everybody, and that's what we try and remind everybody is this is what we're doing to the point of what's our added value from MDVIP. That's one of the things that we do. It helps out everybody, because if we're fighting in Maryland, we're fighting for all of you in Maryland. We're not just fighting for MDVIP. So, Medicare, no, as long as you're either opted out of Medicare, and then if whatever you're charging for, then it's okay, or if you're in Medicare, you're doing it at least per their law. I mean, one little example, if I can add, if you're not doing what you're supposed to against the Medicare or insurers, I don't know if any of you have followed this whole thing that's happening in the lab industry about the cardiac inflammatory labs. But HDL Health Diagnostic Lab got investigated, went bankrupt. Their CEOs made millions. Then there was this sales force that's the same people, and they all made millions. And then this sales force people went and started another lab and bought the assets of this lab. And now patients they didn't balance bill any patients. Patients are getting thousands of dollars in bills because the docs were just ordering tests quarterly, because the docs were getting processing fees. Now, if you know Medicare will pay you $3 for a processing fee maybe to spin down the blood, send it off. They were paying these docs like $20, $25 per sample. And some were even getting more because there were 2 labs. So the patients have gotten bills now where they didn't think they were. Doctors are now getting bills, getting letters saying the bankruptcy estate can go after the docs. Anywhere from a couple hundred to $30,000 to a couple $100,000. You have to pay this back within 90 days or we're going after you. And that's from the estate. So just to the point of running afoul of Medicare, because they were charging all this money, it's not just the lab that goes out of business, but the docs and the patients are now really being hurt. So my only point in all of that is, if you're taking Medicare and you're just charging for access, I don't know that the government would never come down on that, but I think generically if you're doing something for your money that's not access, I think you're good. If you're good with that answer, if you like that answer.
I like that
Okay,
answer.
good.
And, yeah, just a second, oh, go ahead.
Okay.
Rob Briskin.
Do I really have to? You asked me enough at breakfast this morning. Go ahead, I'm kidding.
Exactly. Okay, along those lines, I got a letter from the bankruptcy
Of HDL.
people from HDL, and you know, it was interesting that they sent it by regular mail, not by certified mail. That was one thing. And they said if you paid us within a week or something, we'll give you 10% discount. And number one, I'm not going to ask you in detail about that, but the letter that they cited by OIG said after June 25th, 2014, that this was something that may become an issue about getting the handling fee. And I said, well, that's interesting because I didn't do business with you after June of 25th, 2014. Why do you want $12,000 from me for the handling fee? So I don't know if there's any law firm that's handling this on a national level, but it was interesting.
Yeah,
So,
I don't know.
Okay, let me ask you the concierge question. Number one, the second wellness visit separate from the Medicare covered wellness visit. Do you have to tell your doctors to do 2 of those a year? Because one is reimbursed. And then the other thing is, do you do anything to grow the physicians who are affiliated with your practices and approximately how many patients per year? And the last thing is on the transition of the practices. One of the advantages of MDVIP, as we spoke about, is that you can provide succession. In other words, you'll buy the physician practice. What percentage of the annual retainer revenue are these physicians getting for their practices?
There's a lot of questions, okay. I'm gonna try and start one where, so from the lab perspective, I was just bringing that up. We have no relationship. I mean, our docs were using Cleveland Heart Lab, so, and I know nothing more. I just know about this because, you know, Cleveland Heart Lab keeps telling me, look, we didn't do this and everybody else did, so that's how I know that one. Okay, I'm just gonna start. So with Medicare, what we tell our docs when they come in, when you're doing your MDVIP wellness program, because those services are separate and distinct from a Medicare annual wellness visit, a Medicare subsequent wellness visit, an IPPE, or a commercial physical, those services are really, we did this clear black line, they do them together. So when you come in for your MDVIP wellness program visit once a year around your birthday, then they will do, you know, in our EMR we have templates, right? So the template pulls down, do you want your Medicare annual wellness visit, your IPPE, your commercial physical, and then with your MDVIP wellness program. So they do them together. We had a lot of research, lobbyists and all, showing that with our services, we were called to do them together, document together. So patients don't, you know, when you look at what a patient pays for with MDVIP, there's no an ankle brachial index, I need a stethoscope, but there's no stethoscope, there's no physical. Of course, with Medicare, there's no physical either, but we won't go there. But let's say commercial physical, you know, you're supposed to do an examination, review systems, all that. That's the part that's the covered service part, so they bill for that. Transition takes about 4 months with MDVIP. We put employees in your office to help talk to the patients. We do patient forums to bring your patients in. There's a lot of analytics and all to show you where you're going to go. You open after the 4 months. And then, you know, a third of the retainer fee goes to MDVIP to recoup the investment from the 4 months, and then ongoing regulatory, legal support, marketing. So I'm getting to the marketing piece. Marketing, medical support, the EMR. We have patient portals and physician portals that have proprietary workouts and educational information. Marketing and then succession. Those were the 2 parts, right?
Right, the succession after the doctor
Right,
retires.
okay. So marketing, we do a lot of grassroots things locally. We have a field force that goes in with the docs. They do community events. They do things with support from us to try and bring in more patients. And then it depends on the region what works, you know. Succession retirements, we have about 30 physicians who've retired so far. I'm looking at my colleague over there who's about 40? Okay, thanks. We have about 40 who've retired to date, and then we have about, we have a good 150 docs in the network who are over the age of 65. So who will be thinking of retiring at some point, God knows when with some of these people. And so we work depending on what you want, but we've worked the 30 that we've done so far. We've actually interviewed, brought in another physician, and so that physician has paid the MDVIP docs, so they've monetized their practices upon retirement, and I can tell you it's not $10,000 or $20,000 like I got when I left practice, but you know, we're talking more like 6 figures to monetize your practice when you retire. We have just started embarking on purchasing practices of retiring physicians, and we now have our first employed physician, so that we've put somebody in that practice and employ her. And so we're piloting that in a couple of practices. And then we're actually looking at, can we find independent physicians who are ready to retire and can't find a physician who wants to come in, looking at purchasing those kind of practices.
So, Rob, we don't have any more time.
Yeah, he's given me this thing in the back. I'm here all day. We'll talk more later.
And I imagine we could ask you questions for hours, but we have to take a break. It's 10 o'clock. I hope everybody will go over to the Silk Road room and hang out with the exhibitors and people who have granted us money, and go around to their exhibits and ask a lot of questions, because that's a very important part. And there's snacks and stuff over there.
Thank you.
We'll be back here at,